Okay, this is the first in our series of student-led journal clubs focused on COVID-19. Jess Jackson, student Dr. Jackson, is the self-proclaimed and maybe voluntold ringleader of this organization, which consists of 8 or 9 high-performing student doctors who I've grown to know better over this exercise. So I appreciate everything you've done, Jess. And with that, I'll turn it over to Ms. Shelley Boyer to do formal introduction.
Thank you, Dr. Staudinger. It's my pleasure to introduce third-year student Dr. Jessica Jackson. Jess received her BS in computer science, graduating cum laude from Arizona State University before being accepted into KCU's Doctor of Osteopathy program. She has been an exemplary student at KCU, earning honors designation in internal medicine, pediatrics, surgery, and psychiatry on her COMAT exam, along with KCU's COMLEX I Excellence Scholarship for scoring in the 90th percentile on her COMLEX exams. During the quarantine pandemic, she organized and led a student research project summarizing COVID-19 research, creating a comprehensive resource for medical students. Her journal club presentation today has us taking a deeper look into COVID-19 and some epidemiological factors to consider with this pandemic. I will hand it over to you, Jess.
All right, just share my screen. All right, so this, as I said, this journal club project is on the epidemiology and transmission of COVID-19 and the revelations that have occurred from contact tracing. So as a little bit of a background, early in the COVID-19 epidemic, there were very limited testing supplies in most countries, and that limited their ability to perform a significant amount of contact tracing and testing. Priority was given to the more severe cases of COVID-19 infection, and for the most part, they weren't really able to test mild cases or even test for asymptomatic cases. And so little research was performed on, for example, the prevalence of COVID-19 infection in children during the early days of the epidemic, because children did not appear as a group to be getting very ill. So my first article here, which was published in the Lancet magazine, or the Lancet journal, was on the epidemiology and transmission of COVID-19 in 391 cases and 1,286 of their close contacts in Shenzhen, China, and it was a retrospective cohort study. What the study did was they did an analysis of research and testing performed by the Shenzhen CDC in China. After the first case was identified in that area, the local CDC had begun to create a bunch of screening programs to identify individuals who were sick with COVID-19. Once they identified those individuals, they identified their close contacts and tested all of them. And so what they did was they looked at the initial 391 primary cases, or initial primary cases in the area, and 1,286 of their contacts. And this was controlled for having 4 different types of interaction. This includes sharing a home, traveling with the person, sharing a meal with a person, or having social interaction. They generally excluded casual passerby and healthcare workers who wore PPE while interacting with a primary case. And what they did with all of these contacts that they identified here was they tested them with RT-PCR after their exposure. And so, as I just stated, the RT-PCR testing was given to all of the participants. And patients were then like categorized into whether they had been identified via contact-based screening or whether they had been identified via symptom-based screening. Most of the primary group was identified via symptom-based screening. And then it was more of a mix with the second group. Then what they did was they calculated a secondary attack rate, which was the rate at which a person who had one of those defined types of interactions became sick after interacting with this individual. And then it like mapped out their characteristics. And so some of the findings that they had, this table here is table 1. It was looking at the characteristics of the primary cases, most of which who were identified but via symptom-based surveillance, but a few of them were also apparently identified via contact-based surveillance. And one thing that you'll note here is that there seems to be, a lower incidence in the children here, who are being identified. And already you see most of the children here among the primary cases who were identified were identified via the contact-based surveillance. And then another thing that you'll note is that most of the people who were identified were symptomatic, particularly with symptom-based surveillance. I'm actually not really sure why it says no for symptoms on 8 people who were identified via the symptom-based surveillance, but that's a stat they have there. And then contact-based surveillance, 20% were asymptomatic when they were identified. Whoops, in this primary group. And as I said, persons under 20 years were kind of underrepresented here, and they were also less likely to have been identified based on symptoms. And so this second table here looks at the characteristics of the contacts, and it looks at the secondary attack rate, which was the probability that somebody who'd been interacting in one of those situations that they defined before with the primary patient became sick. And so one of the important findings that they found here was that among persons under 20 years, these people were actually equally likely to be infected as compared to the rest of the population. There was a bit of an overrepresentation in the secondary attack rate among 60 to 69-year-olds, as you can see here with the 15.4%. So it does look like those people were a little bit more likely to become ill afterwards. Other important findings that you can see in this chart is that the household and having frequent contact with the primary case were the strongest factors associated with becoming infected. And another thing to note is that even among people who had frequent contact or who lived in the same household with the primary case, the secondary attack rate was only 12.8% and 11.2% respectively, which was a slightly surprising finding given that this is a new disease with a naive population, immunologically naive population. Another interesting result that they didn't put into a chart is that apparently 9% of the primary infections or the primary cases caused over 80% of the secondary. So there was a fair amount of dispersion in the amount of, or in who was infecting everybody else. And some people had disproportionate contribution. Another set of findings that they found was that when they did contact-based surveillance and tested the contacts of these primary cases, they did wind up isolating the primary cases 2 days earlier on average. and they detected the cases 2 to 3 days earlier on average. And so these contexts were spending an average of 2 days less in society, so to speak. And so I wanted to open that up for discussion.
Yuna, I see you have your hand up.
Yeah, hi. Jess, thank you for presenting that. I was just wondering, so you pointed this out, but the primary cases were people who were more likely to have had obvious symptoms of COVID, right? Since they were detected that way. In what ways do you think that excluding the milder cases of COVID affected the data and results?
Well, I think in terms of the data and the results, excluding the, well, like, what do you mean by like excluding the milder cases? Or just like not finding some of the milder cases, do you mean?
Yeah.
I would say that you can kind of see in a way on this chart how it does affect the results right here, where here when you're looking at the symptom-based surveillance, it looks like children are not really catching, this coronavirus, or not getting sick with it, or not being infected anyway. But when you look at this contact-based surveillance, you see that they are in fact catching it. So it kind of can be a little bit deceptive in terms of determining who you should be testing and who you should be looking for. So that would be my answer to that.
Thank you.
Also, on these cases here, you can see that with the symptom-based surveillance, the patients that were screened based, on the symptoms appeared to be getting sicker than the ones who were found based off of contact surveillance.
Jess, I
Yes.
see Yumin has her hand up. Would you take another question?
Sure.
Thanks, Jess. On that note, I also wanted to ask if in future cases that you've looked at or other cases, whether you saw that kind of high infection rate or infection rate in children or people under 20 in like other countries, or do you have any insight on some other studies that might have shown that?
Yes, there have been several antibody seroprevalence studies which have been performed, a few of which have actually been fairly extensive. The country of Spain fairly recently released an antibody seroprevalence study on their population, and when they were looking at the prevalence of antibodies in children, particularly at the age of like 10 to 15 or over, the antibody seroprevalence rate was similar to that of the rest of the population. It does, in several of these studies, it does appear that the seroprevalence is lower in young children, and but it's not an extraordinarily amount lower. So it might be that young children are perhaps a little bit less likely to become infected. And that was, yeah, that was my insight from there.
Okay, thank you.
One thing that I was thinking about is, why it might be that, children don't get as sick, or why they seem to be a little bit less susceptible to being infected.
Jess?
Yeah.
Student Dr. Casham has a question.
Okay. Go ahead.
So Jess, when I read the article, it said that one of the limitations was that the definition of a confirmed case changed to require symptoms near the end of the analysis period. Do you think this could have influenced the results because of the change in the definition?
Sorry, I couldn't totally hear you.
Okay, I'm sorry. I'll just repeat again. The study says that one of the limitations was that towards the end of the analysis, they changed the definition. They changed the definition of a confirmed case to require symptoms. So do you think the change in the definition of a confirmed case would have changed the results?
Yes, I do. Or it would make sense to me that it definitely would have, because if somebody acquires symptoms, first off, the Northern Hemisphere was also in the middle of like a cold and flu season. And so if that person didn't necessarily have a positive RT-PCR, then they acquired symptoms later, it could be, a false negative from the RT-PCR, but it could also be that they caught another illness.
Right, that's what I thought too. Thank you.
Shelley Boyer has a question.
Yes.
Hi, Jess. Thanks for presenting. I was curious if you had any thoughts or insight. They mentioned in the paper that the symptom-based surveillance were confirmed on average at like 5.5 days, and it took like 3.2 for the confirmed just contact-based surveillance. Why do you think there was that discrepancy in sort of the difference in the amount of time it was taking to confirm those cases?
I think that the primary reason is because people were testing positive and likely shedding virus before they actually became symptomatic.
Okay. Yeah. The one other thing that I wanted to just point out in the paper and in the study that I thought was kind of nice was that consent wasn't required from anybody that participated in this type of research. So, coming from medical school, I know that you guys have experience and have seen firsthand that a lot of human subject studies require consent. So this particular type did not. So I just thought that was kind of cool too. So thanks again, Jess.
Mm-hmm. Any other questions, comments?
Good to go.
Okay. All right. In that case, I will proceed on to the next study. And so in this article here, the second article that I picked, it was published as a expedited release by the CDC for one of their volumes. It talks about a cluster of coronavirus disease that was associated with some fitness dance classes in South Korea. So what had happened here was there were several fitness instructors who went to a training class in Daegu, South Korea. And that area was being hit pretty hard by COVID-19 at the time, the virus. And several instructors, I believe it was 8 in total, wound up testing positive for COVID-19 after attending that training class. 6 of those gym instructors were from the Shenzhen region of South Korea. And those 6 worked in 12 different gyms. And so these instructors returned to their home after the training class and subsequently wound up infecting a bunch of different gym members who attended their classes. And so this study specifically looks at the characteristics of the activities that were being performed and the subsequent number of infections by each instructor. Okay, and then so the participant selection, these participants were just found via contact tracing of the known cases, and the analysis was retrospective. Some of the key findings here. So this diagram here, I personally found it a little bit hard to read. We were, Dr. Steininger encouraged us to highlight, some diagrams that, sometimes could be a little bit hard to read, as well as, some of the really nice ones. And I thought that this was, a very interesting diagram because you can mostly see what's happening. You can see that they're like seeing, this one case here, this, square case goes on and infects, these other people, and you can see some of the train that they've done. I found it a little bit confusing in that they defined a primary case or primary transmission as yellow, or the fitness students. And so I don't know, I just found it a little bit hard to read, but I thought it was interesting how they mapped it out. And one thing that you'll see here is that it's kind of a similar pattern to that of the Lancet article, where a lot of these little like yellow squares didn't wind up transmitting the virus to anybody else, even though they became infected.
Is that social distancing?
Would be. They didn't really elaborate as to, what it was, whether, that person lived by themselves or could have been a lot of different things.
Let me make a comment here. In Joplin, at least, there's pretty much living proof right now that social distancing works. In other words, the number of cases in Joplin just recently doubled, and I think one can speculate that it's due to the lack of social distancing that occurred 3-4 weeks ago.
Yeah, for sure. I know that Rogers, Arkansas got hit, or Northwest Arkansas just got hit like a few weeks ago. And
yeah.
So I was always speculating that it came up here from there.
Bentonville.
Yeah. And so some of these findings, what they did when they were looking at these instructors here is that, one thing that they found is, some instructors wound up infecting the majority of their students, and some instructors wound up infecting none of their students. And then there was kind of like a bit of a range between these instructors. Another interesting thing I found here is if you look at instructor A, and her, when she was in sports facility 1, in that class, she infected 70% of the students. But if you look at these other facilities she went to, she was only infecting 10 to 30% of her students. So I found that to be interesting. Another thing that was interesting is if you look at
Jess, you have a couple questions.
Okay.
Shelley.
Okay.
With that comment that you just regarding the sports facility, did they give any background on what maybe the structure or the ventilation or any, the difference between sports facility 1 would have been compared to the others that she did not spread as much?
I don't believe that they did. One thing that they did go into though, is that like if you look at sports facility 9 that like instructor B went to, they talked about how, she infected 3 out of 5 during the class, whereas instructor C was at this facility the entire time, and she had 25 students and didn't infect any of them. So that was one thing that they mentioned.
Thank you for pointing that out. That is a good point.
Student Dr. Bates has a question.
Yes.
Hi, thank you for sharing, Jeff. I just was going to piggyback on Shelley's question about the ventilation system. So I'll just turn mine into more of a comment and maybe a question if you know of any studies that are looking into different ventilation systems. There's a lot of controversy right now about the PE exam with the MBOME, and one of their comments regarding that was that they've made their ventilation system an open ventilation system. And I was just wondering if now that everything's opening up and we're trying to get kids back in schools and stuff, if there's any insight of whether that will help or not.
Yes, there actually have been a couple of studies related to ventilation systems, one of which was one that was also done by the CDC, where it was looking at a case where a single person who was dining wound up infecting several other members of other families across the room. And when they went and examined the style of the ventilation in that specific building, they found that the direction of the spread from the primary individual was following along the path of the air conditioner and the ventilation system, and that this may have been, why she was able to infect people at a much further distance than it would be expected to be able to do. Another study, which has come out fairly recently, was I didn't read through all of the details on it, but it was basically demonstrating that poorly ventilated buildings were better facilities, would facilitate the spread a lot better than well-ventilated buildings.
Okay, thank you.
Okay, there's another question. Yuna has a question.
Yeah. I was wondering the variability for the instructors to infect the different sports facilities. I wondered if some of it had to do with kind of their natural rise and fall of infectivity during their disease course. And I wanted to know your thoughts on that.
Yeah, that was another thing that I was also considering, is like, whoops, I didn't mean to click that. But one of the things with those instructors is, maybe, she probably wasn't in all 5 of those facilities at the same time. And so it could be possible that she was more contagious at that particular time, and that, because I know that a couple of these instructors had fairly mild symptoms, and they didn't specify which ones, I don't believe, but some of them were actually teaching while they were having symptoms. And there's definitely a lot of research that shows that people are most contagious right before and like at the very, very beginning of their illness. In particular, there's a lot of studies speculating, that, up to 40% of transmission could be pre-symptomatic. And those numbers actually vary a lot between the studies I look at. But yeah, the pre-symptomatic transmission plays a role. And then kind of back more on topic, it is possible that, she taught those on different days and that, her immune system has started to kick in. And then, the facility differences still is, a possibility, particularly because if you look at Sports Facility 9, the instructor who was teaching there, who infected 3 out of 5, she only had 5 students to begin with. So.
Student Dr. Kashem has a question now.
Okay.
So, Jess, I was just wondering, because according to this table, it's saying that there's an association between transmission and high intensity classes, such as fitness dance classes. So do you think it would be reasonable that when gyms open up again and that there's, precautions in place, that we only allow low intensity classes such as Pilates or yoga and cancel all fitness dance classes?
Might be a possibility, yeah. That was one of the factors in here that they cited as being correlated, because they were saying that, this instructors see, just taught Pilates and yoga, which are, much milder intensity classes. And so, people would be breathing in and out less. Other things that they were finding associating with, more transmission was a smaller facility size. And one of the things that they were thinking could be a factor would be the amount of movement, because when people move around while exercising, especially if you're moving around a lot, that actually creates turbulent airflow inside that room. And so that was also projected to be a possible factor.
Right. Thank you.
Mm-hmm.
Okay, you're free to keep going.
Okay. And so some other key findings that they found is that they did not find any secondary cases in classes that had fewer than 5 people. So small class sizes were also associated with less transmission, possibly because people were better spaced out, and more distance from each other. And then as student Dr. Casham brought up, that one instructor, or one of the instructors who did not transmit to anybody, instructor C, was teaching low intensity classes and wound up with no positive students after their exposure to her class. And so the conclusions that they had were that higher transmission numbers were associated with larger class sizes, smaller room space, and higher exercise intensity. And they postulated that other possible contributors to transmission were the warm, moist environment of the facility and the turbulent airflow generated by exercise. And I'll leave that open for discussion.
Any questions for student Dr. Jackson? Okay, if not, what I want to do is, again, thank you so much, Jess, for your fearless and intrepid fortitude in moving this group forward. My goodness. It's just such a beautiful thing to watch this all come together and unfold in our new reality. Is everybody doing okay out there? In particular, I have a specific question for you, Stephanie. I think I'm digging your RV. Are you living in an RV right now?
I am, and I thought of you because I know that's how you got through your master's program, I believe.
Yeah, PhD.
Yeah, so I live with my fiance, and his parents are 70, and my parents are between 65 and 70, so we didn't feel safe living with them. So we are RV life to socially distance from our parents.
Awesome. Where are you?
We're in New Jersey.
Oh my goodness. That's fantastic. I wish I was you right now. You man, are you doing okay?
Yes, sir. I'm just chilling at home mostly.
Oh, good. Say hi to Marcus for me, and I have his number. I'll be texting him shortly. Zarin, you did such a great job today. Thank you so much for your participation. I think I'll leave it there and just turn it over to Shelley to say goodbye to everybody. Again, student Dr. Jackson, congratulations on everything you've accomplished. You deserve everything good that's coming your way. Just know that. Okay?
Thank you.
All of you do.
Okay, well, thank you again, Jess, for your presentation, and thank you everybody for coming and participating. Continue to spread the word about the Journal Club, and hopefully we'll see everybody back here next Friday at 1 p.m. So have a good weekend, you guys. Be safe.
You too.